Hello, everyone, and welcome back to Physio Minds. I'm your host, Alex. That's our co-host, Theo. Today, we have a little bit of a special episode talking about EDS and POTS. EDS stands for Ehlers. I'm probably going to butcher the name here, Theo, but
Ehlers-Danlos syndrome.
Ehlers-Danlos syndrome, and POTS meaning postural orthostatic tachycardia syndrome. So let's talk a little bit about what POTS is first, because that's something that Theo, I think, has seen in the clinic as well as EDS. So how does POTS present in the clinic, or what have you seen?
Right. So typically, POTS is people don't come referred to PT for POTS. It's kind of like a comorbidity or like a secondary diagnosis. And it's one of those things that, a lot of people have orthostatic hypotension where they stand up, blood pressure drops, things like that. In this case, they have orthostatic, when they change positions rapidly, they have tachycardia, which means their heart rate jumps up. So these are people that you might test them in sitting and they're like over 100 beats per minute. And then they stand up, heart rate shoots up, and they get dizzy, pass out, things like that. So it's serious. It's a serious comorbidity you have to be aware of, especially when coming up with like treatment interventions, plan of care, things like that. And there's good research to show that you have to do, when you're dosing exercises, there's actually like a protocol. I forget where the protocol is from, but you kind of start on an exercise bike, for example, and you start 2 minutes at a time before symptom onset. If you can do 2 minutes and you're fine with no increase in symptoms, then you can progress the next day. Let's go 3 minutes, 4 minutes, and so on and so forth. And I believe it's like a 10-month cardio program. So the plan of care for that is long. Yeah. But people see like great results with it. So
I'm just thinking long term, like we can only see somebody for so long in PT until we discharge them. So I'm thinking that's someone we're going to see maybe in the beginning more often, and then every few months or every few weeks, I should say. Right.
Yeah, 100%. Like this is type again, like if you're treating them solely for POTS, which is not always the case, you're gonna probably see them like the first week, once, twice a week. And then after that, when you see they're independent with their program, you might see them follow up like once every 2-3 weeks, just like, okay, like where are you now? Are you getting stuck anywhere in the program? Have you noticed any changes, things like that? And you just kind of check in. It's more like a home exercise program that you give them. They kind of have to be independent with it. And then if you're treating them, let's say they have like back pain or they have, knee pain, ankle pain, whatever, you're also kind of treating that as well.
Right. Yeah. And from my understanding is like someone, as an example, is someone, let's say they're sitting in a recliner, they stand up, they'll get that increase in heart rate, right? That rapid increase in heart rate, but lightheadedness, maybe like a fainting feeling. Is that what I'm?
No, they might straight up like pass out.
Wow.
Right? And they don't know they passed out till they wake up.
Wow.
So it's I think how they diagnose it is they do like a tilt table test as well, where it's kind of like raise you up until you kind of pass out almost. Right. They check your blood pressure, heart rate, things like that. And
yeah. I mean, they have to at that point. They have to take you in different positions to see like what causes it and anything like that. That's really interesting. So what have you seen in the clinic that works for the patients when you're working with them? Is there certain treatment that you've done along with obviously with everything else?
There's no particular treatment that, or like an exercise that works great type thing. It's just a cardio program, and it's to patient tolerance to like, I think you stop before provocation of symptoms. And again, it's a secondary diagnosis. It's not something we specifically treat. It's just something to keep in mind, right? Especially when you're coming up with interventions like, okay, like maybe like will spend some time on their laying down on their back, and then, perform exercise on their back, and then, okay, slowly sitting up, making sure they have some time for their vitals to normalize
Right.
before, doing exercises or getting up completely, things like that,
Right.
And yeah, that's it.
Okay. Well, that's pretty cool. So the second one that I have that is pretty important, or that we've talked about previously in the past, is called EDS. So that Ehlers-Danlos syndrome. So that's something that, from my understanding, it's a collagen disorder. It's something that we actually can inherit, right? That's
Right.
almost.
So there's a genetic component to EDS.
Mm-hmm.
And you're right, it is a collagen issue. Your body basically produces faulty collagen.
Mm-hmm.
And for those who don't know, collagen makes up everything in your body, from like muscles, tendons, ligaments, organs even. So like a lot of people that have EDS are going to have multiple like system dysfunctions. Like they're going to have, like, when I do an evaluation for EDS, we're screening cardiac system, we're screening musculoskeletal, neurovascular, genital, urinary, everything.
Mm-hmm.
And then a lot of times they're gonna be like, oh yeah, you know what? I do have problems with bowel movement. I do have, I feel like my heart races sometimes. I also have POTS with EDS. That's kind of like that's very common as well.
Wow.
So, and a lot of times there's multiple types of EDS as well. There's like a vascular EDS, there's classical EDS, there's a hypermobile EDS. In the short time that I've been kind of working with that condition, we've seen classical and hypermobile.
Mm-hmm.
And then I asked about vascular. We haven't seen a lot of that. And my CI, that's one of like, she's like an expert in the field. She's done a lot of research in it. She had said she expects to see 5 vascular EDS patients in like her whole career. So it's like very rare. And people don't typically come, again, it's like a secondary diagnosis.
Right.
It's not, some people do come like, oh, I have EDS and, I'm having some pain, nothing crazy. I want to make sure that I treat it correctly.
Right.
So yeah, that's a little bit of background on that.
Yeah, I guess like the biggest things and now that you're mentioning it, and I've read up on it a little bit more, is like the biggest things is, if you think about the connective tissue that encompasses everything, literally everything.
Mm-hmm.
I mean, you're thinking these people might have collagen disorders within their heart, right? So you're thinking about, is their heart able to pump, or is their valves able to close properly? Obviously, a cardiologist would see them, but the biggest things we have to think about is joints. Are they dislocating anywhere? Is it their shoulder? Is it their knee, their hip? We're thinking about their neck as well, because that's also a very careful place. You want to make sure that their C1, C2 is working well, or C1 on occiput. You want to make sure all of that is working well.
That's actually some of the questions that we asked during the history. Like, oh, have you had like frequent joint dislocations, things like that? And a lot of people will be like, yeah, you know what, like I've dislocated my shoulder multiple times. Like with EDS, like especially hypermobile EDS, like it could be you're so hypermobile, it's to the point that you can sneeze and you pop a rib. You know what I mean? Like you display, yeah. So it's like you just have to be like very careful. And especially like you said, like collagen makes up everything. So even your skin. So like one of the diagnostic criteria is also like, are you able to like raise your skin from your hand? I think it's 3 centimeters, which it's 3 centimeters is pretty significant.
I'm like trying to do it now. I'm like, whoa.
So really, I think that the purpose of this podcast isn't really diagnose anyone or anything like that, but it's just to like bring awareness to this. It's like I think there's new research on it. It wasn't really diagnosed back in the day. But it's one of those things that you want to catch young, because if your joints are moving too much, you're having all these issues, you want to get the proper treatment and have proper resources, proper education, so you can avoid, serious consequences later in life. I a lot of the patients that I treated for were younger, because they have the familial history of EDS. So again, it has that genetic component. So they'll come in, and we'll treat them, make sure they get on the right track. They know a lot of the treatment is education, right? Like, what is EDS? Like, how do you diagnose it? Like, should you be exercising at end ranges? Probably not, right? You already move too much. We don't need to improve mobility. We need to increase stability, right? So,
right.
A lot of it is just education. I think with EDS, you want to avoid the long-term consequences. Like, I had a patient that, discovered she had EDS at 25 and, still young, but at this point, 25, figuring you had EDS, she had like neck pain. She had nerve symptoms, like upper motor neuron symptoms, like on both arms. I hadn't seen her evaluation, but I think she had upper motor neuron symptoms on both arms. When I saw her, she's wearing a cervical collar at all times. Basically, she can't take it off because she needs like a fusion of her upper cervical spine because she just moves too much, right? Moves too much to the point that she compresses her spinal cord, right? So it's one of those things you want to catch early. You want to always like stabilize, and you don't want to get treated by someone that's not familiar with EDS, and then they put you in those end range positions, like trying to improve joint mobility when that's not what you need.
That's not what you need.
Right.
Yeah, no, I 100% agree. That's pretty crazy. That's unfortunate for those who have the joint or have this EDS. I think there was a TikTok. I don't know if you remember. Do you remember that girl who was like flipped her femur,
sure.
like externally rotated all the way and then put it back down? I was like, that's EDS. That's 100%, because we talked about it, and I was like, what is going on? And then I was like, right away it popped into my head. I was like, Theo and I just talked about it. It's 100% EDS.
We can't make the diagnosis of EDS off that video. And even as PTs, we can't diagnose EDS, right? Like, we don't do diagnoses. We do like clinical diagnoses. And most EDS have like a genetic, not a genetic component. They have like a genetic marker that, a doctor can like find, right? And be like, hey, you know what, you have EDS. Hypermobile EDS, there's no known genetic factor yet. So not genetic factor, sorry, genetic marker. So it's more like a clinical diagnosis. There's like special tests, familial history, we check your skin elasticity, history of joint dislocations, things like that. And like, if you meet like a certain amount, then you're like, okay, like, you know what, you kind of present like a hypermobile EDS.
Right. Yeah.
And then we treat you differently. So in terms of treatment, because I remember like when I first saw my first EDS patient, my instructor was like, okay, like, how would you treat this? Right. And I was like, okay, like, I'm going to perform coordination exercises, 3 sets of 25, things like that. Yeah. And then progress to strengthening. Right. And she's like, wrong, because these pages, if you're doing 3 sets of 25, like you're doing 25 repetitions, the collagen is going to stretch. Right. Regardless, you're going to increase motion, which you don't want to increase motion. So what you should be doing is focus more on isometrics and then strengthening 3 sets of 10. Right. So you're doing less reps, more like strength work, working more stability. You're not really doing end range motions, things like that.
That's awesome. I mean, that's not awesome for them, but it's awesome that you were able to experience that. Like, right, because I wouldn't know what to do if you didn't bring it up. And that's the interesting thing about being a PT is we will run into secondary pathologies all the time, or just any pathology. And you have to be aware and you have to be on your toes and you have to do your research. And I think that's what I love about this profession is you can Google things. I think the best way to do it is like do like Google Scholar or something, because that actually is evidence-based material, journals written, peer-reviewed. The best thing right now is being a student is when we get these pathologies, we're able to connect it through EBSCO or whatever, our library base, and we can find treatment options for our patients, which is really nice.
Right.
One of the things I was reading, I was just searching as we were discussing here about EDS, and there's two types that are inherited. It's the autosomal dominant inheritance, the hypermobile classic and vascular EDS. And it says the faulty gene that causes EDS is passed on by one parent, and there's a 50% risk of each of their children developing the condition. So that's pretty high. So 50% of people, if one person has it, will most
a lot of people go undiagnosed, right? It's one of those things that's not really a problem until it's a problem type thing.
Exactly.
So it's just you know, you want to know your family history, you know, health conditions, things like that. And that's why we ask these things. You know,
Right.
and part of the history is kind of like, okay, like, do you have any history of any of these diagnoses, things like that? And this is one that I didn't know about. So like now I kind of keep my eyes open because I think it's more prevalent than I originally thought.
Right. Absolutely. I mean, just thinking about it, you know, having the collagen issue and then overworking them. I'm sure you have to have, I know you said like 3 sets of 10 isometrics and strengthening, but I mean, you really have to hone in on your skills and see how, like, I wonder what they feel because their skin is fragile too, right?
Right.
And their
I
muscles
think
are.
I think to them it doesn't feel any different. It's just one of those things that the collagen is faulty, right? So we've talked about the stress strain curve, you know, and so if you think of a rubber band and you stretch it, right, it's gonna come back to its natural like position, and that's similar to how muscles work.
Mhm.
So if we're with EDS, however, when the collagen is faulty, when you stretch that rubber band, it's not going to come back to its original position. It's going to come back to like um, a longer,
Longer state. Yeah.
yeah. So it's just something to keep in mind when you're coming up with exercise and diagnoses, even prognoses, right? Because a lot of people with EDS, they don't heal properly. They have problems healing because, you know, collagen's even in like your blood vessels and things like that, you know, in your veins, you know, everything. So they don't heal properly. It takes longer for if you have a tendonitis or something, it takes longer to heal. So that's always something to consider with your plan of care. You know, even if it's a simple diagnosis, it might take twice as long.
Right.
You know?
Right. Absolutely. Yeah, that's really interesting.
So the only thing that I kind of wanted to add is I asked my instructor if there was like a website or something that people can go to learn more, you know, just like educate themselves. And the website she sent me was Ehlers-Danlos.com. Ehlers is spelled EHLERS Danlos DANLOS.com. And I believe they also have like different like specialists in that area, like that are listed on their website they can get in contact with. Obviously, you guys can reach out to us. I can put you in contact. If I can't answer your question, I'll put you in contact with, you know, my instructor. She sees so many EDS patients. She's an expert. She's done a lot of research on it. So
yeah, that's really cool that you had that experience. I mean, we've had multiple pathologies coming through our door. I think the most interesting one, it doesn't have to do with EDS or POTS, but I'll just talk about it because I was very interested in this, was basically one of my patients came in, every time they looked up, their hands and feet would go numb. And I'm just like, what? This was during the interview. The patient turned to us and said, hey, when I do this, it makes my hands and feet go numb. And we're like,
that's scary.
That's very scary. Yeah, very scary. We're like, holy moly, what's going on? We have to check everything in the cervical spine, thoracic, lumbar, upper motor neuron, lower motor neuron, everything. We were looking at literally everything. So it turns out that the patient had a fall, and as a result of that fall, they've had these symptoms of numbness and tingling in the hands and feet. And the neurologist is aware. We were able to find exercises that decrease his symptoms. So a lot of like chin tuck exercises, no extension of the neck, minimal rotation at the neck. Even though we have to do it, we just have to be careful he stays in that chin tuck position and turns instead of just looking up and turning. I mean, it was a pretty interesting case because we were doing Babinski, we were doing Hoffman-Sy, we were doing clone, like we were checking for clonus, and that was the first time I've ever seen clonus in a patient's
Right.
foot or wherever we were testing it, right? So it's just interesting to see the things that we talk about in class. And I don't know if we've mentioned EDS or POTS in class before, maybe very briefly.
I don't think I had ever like really heard of it until I went to the clinic.
Yeah, so maybe some of the things you'll hear, or some of the pathologies you hear in class, you only hear about them, and then when you actually encounter them in person, it changes your mind of, wow, like I have to treat this patient now. What do I need to do? Kind of that oh shit moment where you're like, what do I do?
Right.
But the good thing is that's why your clinical instructor is there, and you can kind of ask them. And if they don't know, I'm going to go back to it again, is Google Scholar, or you can go into your library website, go to EBSCO or whatever it searches out to, and then really pull your sources in, write out treatment plans and whatnot, and see what the best evidence-based practice is for that pathology or individual at that moment. And if you don't know what to do, just do something that doesn't cause their symptoms. Try to relieve their symptoms, if anything. That first,
I would even say to go even further than that, like especially with rare conditions, like if you can only find like one or two articles, whatever, things like that, like, and you really like, because at the end of the day, it's like our first thing is not to do any harm, right? So like reach out to like these people that are experts in that condition. You know, maybe they have some guidance, you know, things like that. Because I know, especially with some of these rare conditions, there's not a lot out there, right? It's, you know, clinically, how do you treat something that doesn't even have a diagnosis, for example, yet? You know what I mean? So it's someone with more experience is probably the best resource.
Yeah. And I'm sure the PTs that you're working around with, if they've been in that setting for a while, they most likely have seen one of those patients come in with some interesting pathology where they can kind of guide you through it. And if they can't, obviously, you know, just continue to do your research. And where do you do your research? Online, books, even reach out back to your professors and say, hey, like I saw something interesting. Does anybody know about this at school? Or does any other professor that I could reach out to actually help me with this? All right, everybody. Thank you for coming to our Physio Minds podcast today. I hope you enjoyed learning about POTS and EDS. POTS standing for Postural Orthostatic Tachycardia Syndrome, and EDS, Ehlers-Danlos syndrome. There we go. I got it.
You got it. Yep.
Only had to say it 10 or 15 times before I can actually say it correctly.
EDS for short.
EDS for short, and POTS for the other one, just to make it easier for us. So if you guys have any other questions or comments or concerns, or if you guys want to just talk to us for any general inquiries, just, you know, hit that DM, let us know what's up. Even to say hello, we get a lot of those already. Any questions, you guys are more than welcome to ask us. If it's clinicals or exercise dosage, whatever it may be. You know where to find us. Physio Minds. We're on Instagram, we're on Anchor, we're on Spotify, we're on Apple, Google Podcasts, you name it, we're there. So thank you guys for coming, and tune in for next time.